Welcome to OET Answers.
Occupational English Test. OET Answers Practice Test, Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a GP talking to a patient called Mr. White. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi, Mr. White. How can I help you today?
Hi, doctor. I've been having some issues with my stomach lately. My digestion seems really slow, and after eating I feel full really quickly, even if I haven't had much. I thought it was just indigestion at first, but it's been going on for a few months now.
How long have you been noticing these symptoms?
I'd say around 3 months, but it's gotten worse recently. It started as just feeling overly full, but now I'm also feeling a bit nauseous after meals, and sometimes I've even thrown up.
That sounds uncomfortable. Have you noticed any patterns with what triggers the symptoms? Certain foods, perhaps?
Not really. It seems to happen no matter what I eat, but it's worse after bigger meals. I've tried cutting down on portions, but even small amounts seem to give me trouble. I'm eating much less than I used to, but I still feel bloated and uncomfortable.
I see. Have you lost any weight or noticed any changes in your bowel habits?
Yeah, I've lost a bit of weight, probably because I'm eating less. My bowel movements are a bit irregular now, but I don't have diarrhea or anything like that. Just less frequent.
Have you experienced any other symptoms, like heartburn or pain in your stomach?
There's some discomfort, but it's more of a dull ache, not really sharp pain. And heartburn, yes, occasionally, but not as much as this bloated feeling.
And what about vomiting? You mentioned it happens sometimes. Is that after every meal, or just occasionally?
It's not after every meal, but it's happened maybe 2 or 3 times in the last few weeks. It's usually when I've eaten more than usual, but even then, it wasn't a big portion.
Right, thanks for sharing all of that. Based on what you're telling me, I'm considering a condition called gastroparesis. Have you heard of it?
No, I haven't. What is it?
Gastroparesis is a condition where the stomach takes longer to empty its contents into the small intestine. It can cause symptoms like feeling full quickly, bloating, nausea, and sometimes vomiting, just like you're describing. It can occur for various reasons, but often we see it in people with diabetes or after certain surgeries. Do you have diabetes or any history of abdominal surgery?
No diabetes, and no surgeries either. So what causes it?
It's not always clear what triggers it, but it's related to issues with the nerves that control the stomach muscles. In some cases, viral infections or medications can play a role. We'll need to do a few tests to confirm the diagnosis, but from what you've told me, it fits the profile.
Okay, so what's the treatment for it?
Treatment often involves making changes to your diet and sometimes using medications. We usually recommend eating smaller, more frequent meals to help with the bloating and fullness. Avoiding high-fat and high-fiber foods can also make digestion easier. In some cases, we prescribe medications that help the stomach empty more quickly or manage symptoms like nausea. There are also tests we can do, like a gastric emptying study, to see how quickly food is moving through your stomach.
That makes sense. Is this something that can be cured, or is it long-term?
Gastroparesis can be managed, but it's typically a long-term condition. The goal is to reduce your symptoms and improve your quality of life. Some people find that adjusting their diet is enough to keep the symptoms under control, while others may need medication for a longer period. We'll also keep an eye on your weight and nutrition to make sure you're staying healthy.
All right. It's just frustrating because I used to enjoy my meals, and now I feel anxious every time I eat, wondering how it's going to make me feel.
I understand. It can be tough, especially when something you used to enjoy becomes uncomfortable. We'll work together to find the best way to manage this for you. I'll order some tests to confirm gastroparesis, and in the meantime, we can start with some dietary adjustments. I'll give you a guide on foods to avoid and what might help. Does that sound all right?
Yes, that sounds good. I appreciate it.
Of course. And let's follow up after we get the test results so we can discuss the next steps. If the symptoms get worse or you're struggling to keep food down, give us a call right away.
Will do. Thanks, Doctor.
You're welcome. Take care, and I'll see you soon.
Extract 2, questions 13 to 24. You hear a general practitioner speaking with Mr. Thomas. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes. Good afternoon, Mr. Thomas. How are you feeling today?
I'm managing. To be honest, I'm still trying to adjust. Everything feels different now.
I can imagine this must be overwhelming. Adjusting to life after a spinal cord injury is a big change. I'm here to support you through this, so let's take things one step at a time. How have you been coping with your condition over the past few weeks?
Well, since the accident, I've been in a rehab center. They're doing their best, and I've made some progress with the therapy, but I still feel so frustrated. I can't move anything below my neck, and it's hard to accept that this is my new reality.
I understand. Being diagnosed with quadriplegia or tetraplegia following a spinal cord injury can be a life-changing experience. It's natural to feel frustrated. But remember, your progress in rehab is important, and there are many resources and support systems to help you regain as much independence as possible.
Yeah, but will I ever regain any movement? Or is this it for me?
Recovery after a spinal cord injury can vary significantly from person to person. It largely depends on the level and severity of the injury. In your case, the injury occurred in the cervical spine, which is why you're experiencing quadriplegia, meaning paralysis in both your arms and legs. However, some people do regain limited movement or sensation with time and therapy, but it's difficult to predict the extent. What's important is that the rehabilitation team is working with you on strengthening the muscles you can control and managing any complications related to the injury.
So what does the rehabilitation process actually look like from here? Am I just stuck in physical therapy forever?
The rehab process is multifaceted and designed to help you adjust and maximize your functional abilities. Physical therapy will continue to focus on improving your strength, range of motion, and preventing secondary complications, like muscle atrophy and joint stiffness. You'll also work with occupational therapists to help you learn new ways to perform everyday tasks using adaptive equipment, like voice-activated devices or specialized wheelchairs.
It feels like so much to handle. I've never even thought about needing all these devices before.
It's completely understandable to feel overwhelmed. The good news is that adaptive technology has made significant strides, and many people with quadriplegia can lead fulfilling lives with the right support. We'll take it one step at a time. You'll also have access to a psychologist or counselor to help manage the emotional toll this transition might have on you.
Yeah, the emotional part has been tough. I used to be so active, and now I can't even get out of bed without help.
That sense of loss is one of the most challenging aspects to deal with, and it's important to acknowledge those feelings. It's okay to feel frustrated, sad, or angry. But over time, and with the right support, you'll find ways to adapt. We'll also focus on managing your physical health to avoid complications, which will help improve your quality of life.
Speaking of that, what kind of complications should I be worried about now?
There are several potential complications that we need to keep an eye on. With quadriplegia, muscle weakness and loss of sensation can lead to problems like pressure ulcers, so it's important to have a proper skin care routine and change positions regularly, even in bed. There's also a risk of respiratory issues, since higher-level spinal cord injuries can affect breathing. Are you using any respiratory support right now?
Yeah, I'm using a ventilator at night.
That's good. The rehab team will continue monitoring your respiratory function to see if you can gradually reduce that support over time. Additionally, we'll watch for any issues with bladder and bowel function. These systems can be disrupted after a spinal cord injury, so you'll likely continue working with a urologist and possibly use a catheter to manage this.
That's been one of the most difficult adjustments. I never thought I'd have to deal with something like that.
It's a difficult transition, but with time, many patients learn to manage these aspects of their care more independently. We'll also make sure you're comfortable with the necessary tools and that your care team provides ongoing support.
What about pain? Sometimes I feel this strange pain in my arms or legs, even though I can't move them.
That's what we call neuropathic pain, and it's common in people with spinal cord injuries. It can feel like burning, tingling, or sharp pain, even in areas where there's no sensation. We can manage this with medication, and I'll discuss some options with you that might help alleviate it. We'll also continue to monitor how it changes over time.
I didn't expect to feel pain in places where I'm paralyzed.
It's one of the unique challenges of spinal cord injuries. Neuropathic pain can be unpredictable, but there are therapies and That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear part of a surgical team's briefing. Now read the question.
Right, the next case is Mr. Davis, scheduled for lumbar spinal fusion. Are there any concerns from an anesthesia standpoint?
Overall, his general health is stable, though he has a history of sciatica. We'll monitor for nerve complications during surgery.
Do we anticipate needing any special neuromonitoring equipment?
Given his condition, we should have it available, but we don't expect major issues.
And how are we planning to manage post-operative pain?
He's been on oral analgesics for his back pain, but we might consider using a patient-controlled analgesia pump post-surgery for better pain management.
That makes sense, especially considering the extent of the surgery and the potential for nerve involvement.
Now look at question 26. You hear a nurse talking to her colleague about a patient's visitor restrictions. Now read the question.
They've come such a long way, and she's been asking about them non-stop.
I understand that, but her immune system is so weak right now. Any extra contact could pose a serious risk, especially given her recent setbacks.
They'll only be here for a short time, and I'll make sure they follow strict hygiene precautions.
Even with precautions, we need to prioritize her recovery. I don't want to compromise her health just to satisfy an emotional need, no matter how well-intentioned it is.
We could limit the visit to just a few minutes. That way, she gets to see them but stays protected.
I'd feel more comfortable if we wait until she's more stable. Right now, any exposure is a risk we can't afford to take.
Now look at question 27. You hear a physician talking to a patient. Now read the question. Mr. Sanders, you've been managing your heart failure quite well with the medications we've prescribed, but I understand you've been experiencing increased shortness of breath lately.
Yes, doctor. It's been harder to catch my breath, especially when I lie down. I've also noticed more swelling in my legs.
We've tried adjusting your diuretics, and you've had some oxygen therapy, but it sounds like we may need to discuss some additional options. I want to talk to you about your preferences if your symptoms continue to worsen.
I've spoken with my family about this. I don't want any invasive procedures like a pacemaker or a transplant if it comes to that.
Okay, I understand, and it's good that you've thought about these decisions. Now look at question 28. You hear part of an announcement in a ward. Now read the question.
Due to the increasing number of patients with multi-drug-resistant infections, such as MRSA, I would like to remind everyone about the essential protocols for managing these cases. First and foremost, isolation precautions must be followed at all times. Staff must ensure that patients with known or suspected drug-resistant infections are placed in single rooms or in designated areas. Proper use of personal protective equipment, such as gowns and gloves, is crucial to prevent cross-contamination. These items must be worn upon entering the room and removed before leaving, followed by immediate hand hygiene. This is particularly important as we have seen a rise in the number of these cases. Additionally, equipment used for these patients must be dedicated and not shared with other patients unless thoroughly disinfected. Finally, thorough environmental cleaning is mandatory in all rooms housing patients with drug-resistant infections. Let's all remain vigilant in adhering to these guidelines to control the spread.
Now look at question 29. You hear a presentation about new medication management education program for elderly patients. Now read the question.
Good afternoon, everyone. Today, Emma from the Geriatric Care Unit is here to talk about a new medication management education program for elderly patients.
Thank you for the introduction. What we are working on is developing an educational plan specifically designed for elderly patients who are managing multiple medications. These patients often face challenges like understanding correct dosages, coping with potential side effects, and maintaining adherence to their medication regimens. It's crucial that we consider their cognitive load, possible physical limitations, and the fact that they might be overwhelmed with the number of medications they are prescribed. I am here to get your feedback on 3 priority areas we've identified: risk of incorrect dosages, risk of adverse drug reactions, and
Now look at question 30. You hear a medical professional explaining a diagnostic procedure to a colleague. Now read the question.
treatments for retinal diseases, particularly those that lead to progressive vision loss. Currently, treatment options for such conditions are limited, often requiring invasive surgeries or frequent injections into the eye. My goal has been to find a non-invasive way to administer therapies directly to the retina. I focused on using nanoparticles to transport regenerative compounds to the affected areas of the retina. These nanoparticles are engineered to carry and release compounds gradually, allowing for prolonged treatment effects. I've now developed a method that allows the compounds to be delivered continuously for up to 48 hours through eye drops. This not only reduces the need for frequent interventions, but also improves the chances of retinal repair. In the future, I aim to increase the duration of this treatment window and explore its applications for other retinal diseases.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For question 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Extract 1, questions 31 to 36. You hear Dr. Kate Benson presenting a case study. You now have 90 seconds to read questions.
Hello, I'm Dr. Kate Benson, a physiotherapist specializing in shoulder rehabilitation. And today, I'd like to share a case study about a tennis player I worked with who had a severe rotator cuff injury. The patient, a highly competitive player in his early 30s, came to me after experiencing intense pain in his right shoulder, his dominant arm for playing. He had suffered the injury while serving in a match, and the pain was severe enough to prevent him from continuing. Despite resting for a couple of weeks and trying to manage the pain with over-the-counter medications, his range of motion had drastically reduced, and he couldn't perform overhead activities without sharp pain. When the patient arrived, my initial examination confirmed a rotator cuff tear. The tendons in his shoulder were inflamed, and there was notable weakness in his shoulder muscles, especially during abduction and external rotation movements. An MRI scan confirmed the diagnosis: a partial tear in the supraspinatus tendon, one of the 4 muscles that make up the rotator cuff. Additionally, there was some impingement of the shoulder, where the tendons were getting pinched between the bones during certain movements. The patient was understandably frustrated and concerned, as he had an important tournament coming up in 6 months. He feared the injury might keep him from ever playing at his previous level. I assured him that with proper rehabilitation, he could regain full function, but it would take time and effort. My first goal was to reduce his pain and inflammation. We started with gentle mobilization exercises to improve the shoulder's range of motion. I also prescribed anti-inflammatory medications, and we used ice therapy after his exercises to reduce swelling. Over the next 2 weeks, his pain levels decreased, and we gradually introduced strengthening exercises focused on the rotator cuff muscles. This included isometric exercises, where he pressed his arm against a wall without moving the joint, building strength without risking further damage to the tendon. As his strength improved, we transitioned into resistance band exercises. These help target both the rotator cuff and the surrounding muscles that stabilize the shoulder joint. The key was to ensure he was performing these exercises with the correct technique, avoiding any compensatory movements that could aggravate his condition. For instance, I had him perform external rotations with a light resistance band, focusing on controlled movements to retrain his muscles. After 4 weeks of strengthening, I was pleased with his progress. However, the next step, returning to tennis-specific movements, was crucial. The repetitive overhead motions in tennis, particularly serving, are notoriously hard on the rotator cuff, so it was essential to rebuild his shoulder's endurance and stability. I introduced a modified serve drill, where he performed slow, controlled serve movements without a racket, paying attention to his shoulder alignment and mechanics. This helped reinforce proper movement patterns before we reintroduced racket work. Around the 12-week mark, we started incorporating light tennis drills. The patient began hitting forehands and backhands with low intensity, focusing on keeping his shoulder relaxed and his movements fluid. Serving was reintroduced cautiously, starting with half-speed serves before gradually progressing to full speed by the 15th week. Throughout this period, we maintained a rigorous shoulder strengthening routine, with a particular focus on scapular stabilization to ensure his shoulder blades were moving correctly during tennis strokes. One of the challenges was maintaining the patient's motivation during the long recovery process. To keep things engaging, I varied his exercises and drills regularly and set small, achievable goals each week. It was important for him to see steady progress, even if it was incremental, as this kept his confidence high. By the 5-month mark, the patient was playing competitive tennis again. While his serve still lacked some of its previous power, he was free of pain and playing without hesitation. Over the next few weeks, we worked on refining his serve mechanics, ensuring he didn't place undue strain on the shoulder. By the time his tournament arrived, he felt strong, and though he didn't win, he performed well, and was just happy to be back on the court without discomfort. This case highlights the importance of a structured rehabilitation program for athletes with rotator cuff injuries. By focusing on strengthening the shoulder muscles, restoring mobility, and gradually reintroducing sport-specific movements, we can help athletes return to their sport at a high level, while minimizing the risk of RE injury.
Extract 2. Questions 37 to 42. You hear a conversation between a journalist and Dr. Walker discussing psoriasis. Now, read the questions. You now have 90 seconds to read questions.
Hello, Dr. Walker. Thank you for joining us today to discuss psoriasis. Can you start by telling us what psoriasis is?
Of course, it's my pleasure. Psoriasis is a chronic autoimmune disorder that causes the skin cells to grow too rapidly, leading to thick, scaly patches on the skin's surface. These patches, known as plaques, can appear anywhere on the body but are most often found on the elbows, knees, scalp, and lower back. The underlying issue is that the immune system mistakenly attacks healthy skin cells, causing them to build up too quickly, faster than the body can shed them.
Interesting. Is psoriasis common, or is it more of a rare condition?
Psoriasis affects about 2 to 3% of the global population, so it's fairly common. It can begin at any age, but it most often develops between the ages of 15 and 35. Certain environmental triggers, such as infections, stress, or skin injuries, can cause flare-ups, making the condition unpredictable. Although psoriasis is chronic, the severity can vary from mild to severe depending on the individual.
What about the different forms of psoriasis? I've heard there are multiple types.
Yes, there are several types. The most common is plaque psoriasis, which accounts for the majority of cases. These plaques are thick, raised areas of inflamed skin covered with silvery white scales. Another type, guttate psoriasis, presents as small red spots on the body and is often triggered by bacterial infections, like strep throat. Inverse psoriasis, on the other hand, tends to appear in skin folds, such as the armpits and groin, and has a smoother, less scaly appearance.
That must be very uncomfortable for the patients. Does psoriasis only affect the skin, or are there other health risks associated with it?
Psoriasis is more than just a skin condition. It can affect other areas of health as well. Up to 30% of psoriasis patients develop psoriatic arthritis, a painful joint inflammation. Additionally, psoriasis increases the risk for other chronic illnesses, including cardiovascular disease, diabetes, and even depression. The psychological effects can be profound due to the visible nature of the disease. Many patients experience anxiety, low self-esteem, and social isolation.
Can you talk us through some of the treatment options for psoriasis?
Certainly. Psoriasis can't be cured, but it can be managed. For mild cases, topical treatments such as corticosteroids, vitamin D analogs, and moisturizers are often effective. More severe cases might require phototherapy or systemic treatments like biologics or oral medications that target the immune system. One of my patients, David, had plaque psoriasis that spread to his scalp and hands, which was distressing due to its visibility. We shifted to a biologic treatment after his condition worsened. Thankfully, it helped reduce his symptoms significantly.
I imagine the mental health aspect is significant too. How do you address that?
Absolutely. The emotional toll of psoriasis is often underestimated. Many patients feel ashamed of their appearance or worry about what others think, which can lead to social withdrawal. It's vital to offer psychological support alongside medical treatment. Counseling and support groups can be incredibly beneficial for patients struggling with self-image and anxiety.
That is the end of Part C. You now have 2 minutes to check your answers.